faculty who is here, if you have any questions for Dr. Curtis? Dr. Rahul? Sharad, Dharma, any one of you?
Yeah, Sharad here, sir. Sir, any experience with the low-dose dasatinib, Dr. Curtis? Because that's something which we are looking at in our Indian scenario, the low-dose dasatinib data.
I showed you briefly the data of the start with 50 milligrams daily, and it looks very effective. I think for the frontline setting, 100 milligrams, of course, works well, but I think 50 milligrams is probably enough. So the data that I showed you looks very, very positive. The follow-up is short, but I have no reason to believe that it'll look any different with longer follow-up. I think it'll be fine.
Right.
Thank you, Dr. Curtis. Others?
Yeah, sir, I have a question.
Go ahead.
Actually, this is a very pertinent question, sir. In recent times, actually, the patient's COVID positive patient, first diagnosed CML. I have encountered a young patient. I planned for dasatinib, but incidentally, patient diagnosed with COVID-19. So what is the best drug for this patient at this moment when the patient is having count of 3 lakhs, huge splenomegaly, first diagnosed with CML-CP? So what is your suggestion? I started with imatinib. I don't know whether I am right or wrong.
Well, you're right. I mean, it's a good option. We have been collecting data through the International CML Foundation from colleagues from all over the world, trying to understand these kind of questions. What do you do now that we have this serious health problem all over the world? Although this is merely observational and from the reports that we received spontaneously, it appears that there doesn't seem to be any difference for or against any of the TKIs in terms of their safety or efficacy if they have the COVID-19. So it appears that using any of them is fine as you find appropriate based on other features. We do not seem to see any higher risk of acquiring COVID-19 or of having a more severe manifestation of COVID-19 with one or with the other. Now, imatinib is a good drug, so you did fine. But we've seen patients with any of the other TKIs do well.
Thank you.
Thank you, Dr. Curtis. Dr. Tufan, any question? Chandrakala?
Sir, what is the role of interferon actually? Because now we got many TKIs, and interferon is out of CML, or do we have does interferon still plays a role in CML management?
I am not too excited about interferon. Perhaps on a patient that has failed everything else, to consider it. But the studies that I showed from Germany and from Australia, to me, they don't look as impressive. You get more toxicity and you get more cost and you get more inconvenience because it's subcutaneous administration and all of that. And I do not see yet a benefit. The only caveat, the only question mark that I have, and which could help me change my opinion, is when they get to the point of starting to discontinue therapy in some of those patients, if the success rate of treatment discontinuation is better, if we have fewer patients who lose their response after treatment discontinuation, well, then it might be that it's beneficial. But even then, I would argue, do you need to use the combination from the time of diagnosis, or should you use it just for a year or two before you stop therapy and then stop therapy? That would save some years of administration to the patient, but that will have to be addressed with the study.
Dr. Tufan, sir, Agarwal, sir.
Yes, Tufan, go ahead.
Yes. So when you consider the bosutinib first line in your patient, because the dasatinib is there, the nilotinib is there, the bosutinib, there is a short follow-up data is there. So did you ever consider the bosutinib as a first line in your patient?
I'm sorry, I didn't hear you well.
Patient profile for selecting bosutinib as the first line TKI.
Well, bosutinib seems to have the lowest risk of arterial occlusive events of the second generation TKI. I still think that imatinib has less of a risk. But of the second generation, I think that bosutinib has the lowest risk. So that is one group that I think that clearly can benefit from bosutinib. If I want to use a second generation and I have a patient that has risk factors for arterial occlusive events, diabetes, hypertension, hyperlipidemia, smoking, whatever, I would definitely use bosutinib. Now, any other patient that you want to use second generation TKI is fine for bosutinib, but that is one area where you can differentiate perhaps a little bit.
Right. Pankaj, anything? Yes.
What is the role of BCL2 inhibitor venetoclax in CML?
What is the role of, I'm sorry?
Venetoclax.
Well, that's an interesting question. It has shown very nice synergy. One in the blast phase, and that could be valuable because, of course, in blast phase we don't have treatment. But also in eradicating the leukemic stem cell. So that could perhaps be beneficial for patients who you're trying to get to treatment discontinuation to either make more patients eligible or decrease the risk of relapse. And some of the studies are ongoing on that. We don't have any clinical data yet, but there are studies ongoing.
Sir, is there any role of aspirin or any warfarin anticoagulants in patients on nilotinib or ponatinib?
Well, we've used it I guess out of need, but I think that the likelihood of them in benefit is low. Because the two drugs, well, dasatinib and ponatinib, they both inhibit platelet aggregation, which is why we use aspirin. So I think that there's probably very little that aspirin can add to that effect. Now, aspirin is fairly safe. Well, it could increase the risk of some bleeding, so I guess you could use it. But I don't know that it is effective, and one, there's no prospective data, and two, again, some of these drugs that have an increased risk of these events already have an aspirin-like effect on platelets.
So, Dr. Curtis, one question. The patient who achieves second chronic phase after second generation TKI, like the dasatinib, from the blast crisis came to second CP. Will you consider the stoppage of the dasatinib if it's achieved the MR 4.5 for a long period?
Absolutely not. A patient who has gone to blast phase anytime, I would never consider them for treatment discontinuation. I think that would be, unless there's prospective studies that demonstrate this, would I enroll that patient in a clinical trial? Yes. But that is one scenario where I don't think that it should be done outside of a clinical trial.
Dr. Curtis, wonderful presentation indeed. You presented some interesting thing about sequential TKI usage. Would you do that in your clinical practice?
Data on what, I'm sorry?
Repeat your question, please.
No, sir. The sequential TKI usage in chronic phase chronic myeloid leukemia, does he do it in his clinical practice?
Sequential use of TKIs.
Yeah.
Well, we do that in one way or another because of patients' toxicities or whatever. So I think we do it. I don't know if your question is in doing it, for example, starting with a second generation and then maintaining them with an imatinib, for example, once they reach a deep molecular response. And that is an interesting approach that it hasn't been done prospectively. My guess is that it could probably work. and it'll save you, some money and risk for the arterial-occlusive events. It could have some potential advantages, but it hasn't been done prospectively. But again, if I had to guess, I think it could work.
Thank you.
Others, any questions? Yes, Pankaj.
Dr. Curtis, I have many patients on dasatinib, 150 mg and 100 mg upfront. I am encountering one problem daily. A patient on 100 mg dasatinib are coming with severe pancytopenia. Not only severe pancytopenia, but it is a long-standing pancytopenia for 1 month, 20 days to 1 month. We are doing bone marrow in between, but that is absolutely normal and hypoplastic, and patient recover after 1 month to 1 or 40 days or 45 days. So what is your experience regarding myelosuppression in dasatinib 100 mg?
It certainly happens. It doesn't happen more than with the other TKIs. It happens same as everything else. Perhaps bosutinib has a little bit less neutropenia, but not thrombocytopenia. And remember, bosutinib doesn't inhibit SIK, so there may be some rationale there. But we do see that. Definitely, that's a patient where you may want to lower the doses. And one of the benefits that we've seen with starting with the lower dose with the 50 milligrams is precisely that you see less myelosuppression. But still, there's a few patients who have that product. The majority of patients that have myelosuppression, eventually over time it gets better. You can support them and eventually it gets better. But there's the occasional patient where it remains a constant problem and there's very little you can do. We have done a study using a thrombopag on patients that have chronic thrombocytopenia that they don't respond. We're hoping that it will be published soon, and it's currently under review. And it works very well. So for those patients where thrombocytopenia is an issue, a thrombopag is a good option.
And if patient recovers from the thrombocytopenia with L-thrombopag, you go back to the same TKI or you will use a different one?
Well, usually, in most of the instances, I went to the same one because although cross intolerance is uncommon with TKIs, thrombocytopenia seems to be the one adverse event where there is more cross intolerance. The patients that have severe thrombocytopenia, they tend to have it with, most of them, they tend to have it with whatever else you give them. So I would probably go back to the same one. Curiously, some of these patients that we included on that trial, we not only were able to get back to the same TKI, but in a few of them, we were able to go back up on the dose. So, maybe it's something to consider.
If a patient on imatinib in a deep molecular response now shows rising creatinine, what's your approach? You sort of precipitated a treatment-free remission, or you change over to another one?
Well, yeah, it depends on the situation of the patient. If the patient is ready for treatment-free remission, meet the criteria, and the patient is interested, because not every person wants that, but if they have that, then yes, you can consider doing that and monitor closely as we would do with any CFR patient. But if you're not there, then you can either lower the dose or change to a TKI. And here I would select either dasatinib or nilotinib. So those are the ones that have, in our experience, the least effect on the kidney. Bosutinib has some more similar to imatinib.
Is there a consensus now about the ponatinib dose, 30 or?
Well, we just presented the preliminary results of this study called the OPTIC trial. The OPTIC trial was randomized for chronic phase patients that had resistance or intolerance to 2 or more TKIs. And they were randomized to start at 45, 30, or 15. And the patients that started at 45 or 30 were required to go down to 15 once they achieved a response. And the response for this study was defined as a BCR level of 1 or less 12 months. And what we found is that the response rate is significantly higher with 45. It's 38% compared to 27% with 30 or with 15. 30 and 15 were identical. And that difference is particularly large in the patients that have T315I. The arteriocclusive events were a little bit higher with the 45, but the difference was very tiny. We had 5% with 45 and 4% with 30. So there was only a 1% differential in these events. So looks like the gap in efficacy is much larger than the gap in safety. So with that, I would say that particularly in a patient that has T315I or that has failed more therapies, in a more difficult situation, I would use 45. If the patient, but keep in mind that perhaps one of the things that helped us with the safety was that lowering of the dose once they reach a response. That may be the trick that we did not do initially with the early studies with ponatinib, that intentional dose reduction once they reach a good response.
Right, so there's a question about mutation analysis when a drug fails. Is Sanger's adequate, or you will go for NGS?
With NGS, you're going to find more low-level mutations. You'll find probably an additional 10 or 15% of patients with mutations. I still have a question about what does it mean to have a mutation at such low levels? Is it really the driver of the resistance? If it represents 1% of the total clone, is it really driving the resistance? So, I mean, right now in clinical practice, I still use standard sequencing, Sanger sequencing. In research, we are doing NGS, but in clinical practice, I follow Sanger sequencing.
Another question is, are there any mandatory indication to start second generation TKI upfront? Any mandatory?
Not mandatory. I think that you do it according to your patient's goals and things like that. I think any patient that may want to consider the possibility of treatment discontinuation, better to start with the second generation. There are patients who, particularly perhaps some of the older or more frail patients, that you just want to have as little toxicity as possible and have a longer life, and that's all. Then imatinib is a good choice, and I think it's important to emphasize that imatinib is a good choice. But certainly you have a better chance of getting to a TFR with the second generation.
From same token, there is a question, is there an exact time limit for how long there should be deep molecular response before you suggest TFR? After imatinib, after dasatinib, after nilotinib, and after bosutinib?
Well, to me, the minimum is 2 years. I showed you, Eurospeed considers 1 year, but to me, the results look very different. So the minimum I consider is 2 years. The optimal I consider is 5 years.
That's for each one of them.
It's the same for all. Curiously, once you reach that, it doesn't matter which one it is. You have a better chance with the second generation, but yeah.
There's one question about CML P190 variant. What will be your suggestion for the best treatment?
Those patients have a worse prognosis. I think that's a scenario where you may want to favor a second generation TKI, with the understanding that we don't have prospective data to show that they're better. They're not common, so there's been no real studies to show that they're better. Anecdotally, experience has been a little bit better, but it's anecdotal. So, but even then, that's what I would.
Right. Accelerated phase of CML. Will you go for transplant, or you will still try with TKIs only?
I would try TKIs, but I would start looking for donors. Their outcome long term is about the same. Now, for a younger patient that has an excellent donor and all that, you know, if you don't get a good response quickly with a TKI, I think it's worth considering. But my first approach is TKI.
Another question is about TKI resistance. If no mutation is found, what is the next commonest cause?
You know, we became so obsessed with mutations that we forgot to look at other causes. We are starting to learn that some patients have other molecular abnormalities that may be driving the disease together with, or maybe be the main drivers of the disease. You know, some time ago, there was some talk about the transport of the drugs. That applies to imatinib, but not to the other drugs. So we don't really understand the mechanism of resistance. And in some way, I prefer a patient with a mutation than with no mutation. Because if you have a mutation, you know what's happening, and perhaps another TKI will work. If I don't have a mutation, you know, for example, in the ponatinib studies, if you look at the data, the worst responses are in patients that have no mutation, possibly telling you that there are other drivers of the disease that we don't know yet.
Right. Faculty has any other questions?
Dr. Cortes, how would you practically manage pregnancy in chronic phase CML?
Well, you know, we're also hopefully we're going to have our manuscript out soon. It's under review. I take a very minimalistic approach. And you can think here about three possible scenarios. One is the planned pregnancy. That's the easiest. You try to bring them down to the lowest possible PCR transcript level before stopping therapy for the pregnancy, and then maintain it off for the duration of the pregnancy. The next is the unplanned pregnancy. A patient is taking a TKI and becomes pregnant. I stop the TKI as soon as I recognize the pregnancy and monitor the patient. So for these two first scenarios, what if you start seeing that the transcript levels start going up? I don't do anything. I just watch them. You know, you only need 9 months. And if the PCR keeps going up, my experience has been once the baby is born, you reintroduce the TKI, they respond. So I'm not worried about that increase. I've only had one last patient during pregnancy. That was the one patient where one of my colleagues used interferon. I don't use interferon. And the reason for that is because although it has been mentioned that it's safe, it may be safe. Number one, remember that the responses to interferon take a long time to occur. The median time to a cytogenetic response, cytogenetic, was 12 months. For molecular response, so it's placebo for us, for the doctor. You know, we feel better, we're doing something, but it's not going to help. And you know, it has side effects, fatigue and depression, and all these things. And the most challenging scenario is the patient that is pregnant, and then you diagnose CML. Because then, of course, the disease is very active. So it's more challenging. What I do is I allow high white cell count. I mean, if the white cell count is 60 or 70,000, that's fine. As long as the mother is doing okay, there's no signs of acceleration or anything, and the baby is growing okay, I don't do anything. If there's too many symptoms, or the white cell count is going up too fast, or spleen or something, I use short pulses of hydroxyurea. It's more effective and more rapid to bring the white cell count than interferon. I don't keep them on hydroxyurea all the time. I give them a few days, bring the white cell count down. Doesn't have to be normal, just down to the 20s or something, and then monitor. Now, in the third trimester, you could use TKIs. If things start getting a little bit complicated, then you could use the TKI in the third trimester. It seems to be safe for the baby. So I've done that in a patient or two.
Thank you, Dr. Cortes. We're waiting for your manuscript on this.
Well, I'm responding to the reviewers. Hopefully, it'll come out soon.
If the woman has come to you in second trimester and she's taken the TKI through and through all first 3 months, and she asks you for the opinion whether she should terminate the pregnancy or continue, what do you advise?
Well, in the second trimester, some of the fertility experts that I discussed this, it's safe already to do the TKI. So I don't feel as comfortable in the second trimester, but if the baby is growing well and has no obvious evidence of malformations with an ultrasound and studies, etc. Now, I would prefer to stop the drug if the patient is stable and continue. It's the mother's decision about the treatment, the interruption of the pregnancy. But the issue is mostly assess the status of the baby at that point, because obviously they have been exposed through the most critical period, and it could be that you already know that they have a malformation. That is information the mother has to know so that they can make an informed decision.
And no breastfeeding on TKI?
No breastfeeding on TKI, that's correct.
Any suggestion about pediatric CML? Any drug of choice or anything?
No, but little by little we're learning that they all seem to work and seem to be safe. There's already a little bit of data with TFR, so it's the one thing that we see is that the children end up being shorter. That's the main difference in terms of adverse events, that the effect on their height. They're healthy children, but they're just shorter.
Imatinib produces growth retardation and all these things. Are there any preventive steps or any?
Preventive steps for what, I'm sorry?
Growth retardation, bone metabolism, all these things. Are they restricted to imatinib or they are with all the TKIs?
No, they are with all of them. And I don't know of any preventive measures, although, I haven't seen anything.
Right. Well, I think we are almost towards the end of 2 hours. Yes, Pankaj, you still have a question, yes.
So last question, sir. Sir, how will you manage a case of CML with CNS blastitis?
You certainly need intrathecal chemotherapy. We know that the dasatinib crosses the blood-brain barrier, but it's not enough to be dead treatment for CNS disease. You need intrathecal chemotherapy. It helps if you have a TKI that goes to the brain. It may add to the benefit, but I wouldn't just do that. I would do intrathecal chemotherapy, possibly radiation, and then it is usually good to give them systemic chemotherapy with chemotherapy and all that. Even if you don't have systemic disease, eventually those patients can relapse systemically.
Right. Well, I have no words to thank you. This has been a great evening. We have learned something in 2 hours which we didn't learn in last 20 years. If other faculty members would like to respond and give some comments. I'm sure you all echo what I said.
Yes.
We all learned a lot.
Excellent.
Wonderful session. Wonderful sessions. Absolutely wonderful.
Yes.
Thank you very much. It's my pleasure. I really enjoyed it, and I remember very fondly my trips to India. I've had a few, and
yes.
hopefully I'll be able to get back there and visit with all of you and have some wonderful Indian food.
Thank you, sir. So over to the organizers, Lupin, for the last word and vote of thanks.
Thank you so much, sir. Thank you so much for a very enlightening session. And on behalf of Lupin, I would like to extend a sincere gratitude to each one of you present here, Dr. M B Agarwal, sir, Dr. Curtis, and all our panel members. Thank you so much.